Good evening, everyone. I'm Dr. Roma Satvik from Sir Gangaram Hospital and the convener of the SIG research methodology. And this is our third module in, it's an attempt in helping you understand basic statistical concepts the way they appear in papers. This one has been made specially, I'm hoping, friendly to you all, because the format is that we present a paper and based on that, we discuss study design, why this particular study design is suited to a question that has been raised in the paper, and then take you through basic statistical concepts that have been used in the paper. With me today are my co-conveners, Dr. Garima Kapoor from Safdarjung Hospital and Dr. Siddharth Nagireddy, who will be basically conducting this program. I hand over to and two very able students from IFS, and we encourage students from across different colleges to be a part of this. Maybe in future, we would want you to present papers, to be a part of these webinars as these two bright students today with us. So I hand over to Dr. Siddharth. He'll conduct the program.
Hi, it's my pleasure to conduct this program. A lot of learning has occurred in the first two modules. Hope I'm audible.
Yes, you are.
Yeah. So we would start without any delay. The first candidate would be Dr. Aishwarya Chaudhary. She is an IFS fellow in reproductive medicine. She's pursuing her fellowship, I believe, from Safdarjung Hospital. From SGRH, New Delhi. And she would be presenting a very interesting retrospective cohort study, which analyzes the association between fertility treatment and cancer risk in children. And this has been published in JAMA. So they have studied almost like 1 million children, which is a huge number about. And they have studied about 2,000 cancers in that study. And they have analyzed various factors like the drugs used, the growth in progesterones, and the type of ART, whether it's IVB or even the frozen embryo transfer. So the hazard ratios of all these interventions was analyzed on the risk of cancers, and we have the expert Dr. Geeta V from MMM Hospital, Madras Medical Mission Hospital, Chennai, who would discuss this paper subsequently with the candidate. So I wish Dr. Aishwarya good luck, and we all are keen to know what you're going to present on this. Over to Dr. Aishwarya.
Okay, sir. So how do I share my screen from the share option?
Yes, go to the share option at the bottom of your screen.
Yes, ma'am. It shows advanced sharing options.
You have to choose, we can see your screen.
No,
We
ma'am,
saw your
screen.
No.
Choose desktop.
Ma'am, it doesn't show. It is showing one participant can share at a time. Multiple participants can share simultaneously and advanced.
Ma'am, sharing has stopped. You can start sharing again now.
Is my screen visible now, ma'am?
Yes.
Okay. Good evening, everyone. I'm Dr.
Make it full screen.
Yes, sir. I'm doing that now. Good evening, everyone. I am Dr. Aishwarya Chaudhary. I will be presenting a study, a paper that was published in the journal JAMA in the year 2019. And this discusses the association between fertility treatment and cancer risk in children. So why was this study done? Since we know that there are certain risks that assisted reproductive technologies carry with them, and higher risk of adverse perinatal outcomes are seen with it, like prematurity, low birth weight, and congenital malformations. However, the long-term consequences are studied very less. And it has been seen and observed that the use of fertility treatment increases the risk of childhood cancer, possibly due to epigenetic changes. And this hypothesis is also supported by the finding of epigenetic changes in human oocytes, embryos, cord blood, and placentas. So a systematic review and meta-analysis of around 29 studies in the year 2019 was done, and it reported an increased cancer risk in children born after fertility treatment. But this was limited by the small numbers of exposed cases and a possible recall bias, and few studies differentiated between the associations with the treatment and the underlying infertility, and very few studies included information on specific fertility drugs or specific treatment procedures. So it's uncertain whether fertility treatment is really associated with increased risk of cancer in children or not. So this study was conducted in Denmark. The design of the study was a retrospective cohort study, which was carried out between January 1st, 1996 and December 31st, 2012. And a total of 10,85,172 children were, the data of these many children were recorded. And this data was collected from Danish Medical Birth Registry. The objective was to examine the association between different types of fertility treatments and also fertility drugs and cancer risk in children. So what was the cohort for this study? All children who were born alive in Denmark during this duration, that is 1996 to 2012. The unique personal identification number that are given to all the residents of Denmark was used to link the individual level information on children and their parents. And this was used to identify the maternal fertility problems from the database, including maternal use of fertility treatment, the cases, and the types of cancers that were found in children, and any other relevant information. Children were excluded if there was any missing information on sex, maternal age at birth, or multiplicity. And if there were missing or implausible data on gestational length, or if they died on the same day as being born. What were the associations that were studied? So the exposures that were considered for this study were clomiphene, gonadotropins, GnRH analogs, human chorionic gonadotropin, progesterone, estrogen, and assisted reproductive technology, that is IVF and ICSI separately, frozen embryo transfer, and all of these exposures were separately compared with the risk of childhood cancer. And they were compared between infertile women undergoing these treatments and fertile women. The outcomes were measured in hazards ratio and incidence rate differences for childhood cancer. The statistical methods that were used were Cox proportional hazards model to estimate the hazards ratio, and with 95% confidence intervals for any type of cancer. Each exposure, as mentioned before, was investigated separately, and a partial likelihood test was performed to determine if the 4 ART treatments were statistically significantly different. The proportional hazards evaluated based on scaled Schoenfeld residuals, and this detected no violation in the statistical methods. A post hoc analysis of the E-value was performed for unmeasured confounding, for the association between the use of frozen embryo transfer and any type of cancer. A Poisson regression was used for adjusted incidence rates and incidence rate differences with 95% confidence intervals. And all p-values were two-sided, and a significance value of 0.05 was applied. What were the results? So overall, no statistically significant association was found between the use of any fertility treatment, any fertility drugs, IVF or ICSI, and cancer in children. However, children born after the use of frozen embryo transfer were at an increased risk, mainly an increased risk of leukemia and sympathetic nervous system tumors. So as can be seen from this slide. So the incidence rate of cancer, childhood cancer in infertile women was 17.5 per 1 lakh women. And that for infertile women was 44.4 per 1 lakh. Any childhood cancer with maternal infertility, any childhood cancer with that the association with any maternal infertility was not statistically significant. The hazards ratio was 1.02 and the incidence rate was 0.1. The association between any childhood cancer and any type of infertility treatment was also not statistically significant, with a hazards ratio of 1.03 and incidence rate difference of 0.3. The association between any childhood cancer with any type of fertility drugs was also not significant. Hazards ratio was 1.01 and incidence rate was minus 0.1. Any childhood cancer with any ART was also not significant, with hazards ratio of 1.2 and incidence rate difference of 3.5. Use of ICSI or IVF also showed no increased risk. However, now we will come to the important differences that were found. FET, frozen embryo transfer, showed an increased risk in those women, in those children who were born to women who had undergone fertility treatment, with a hazards ratio of 2.43 and incidence rate difference of 26.9. And leukemia as a particular cancer also showed increased risk, with hazards ratio 2.87 and incidence rate difference 10.1. Sympathetic nervous system tumors also showed an increased risk with hazards ratio of 7.82. Coming to the limitations of the study, childhood cancer is rare, so there are very few cases. Like in this study, only 2,000 childhood cancer cases in 10 lakh children that were taken from the database were found. Women may not have, the other limitation was that women may not have used the prescribed fertility drugs, or they may have used it at a different time for a different duration. So misclassification and possible underestimation of the associations is another limitation for this study. And there were many potential confounders. And there was possibility of unknown or residual confounding that could not be ruled out. So the conclusion of this study was that the use of frozen embryo transfer compared with children born to fertile women was associated with a small but statistically significant increased risk of childhood cancer. And this association was not found for the use of other types of fertility treatment examined and other fertility drugs. Thank you.
Dr. Siddharth, are you there? Okay, Aishwarya, that was an excellent presentation, but it uses very complex concepts. We are not going to go into all the complex concepts of this paper because that might probably need a whole week to explain. We'll be talking about some basic stuff in this paper, starting with study design. And understand that this is a question that is dealing with a very rare outcome. And it is also an outcome that develops over a period of time. It's an outcome that takes maybe 10 to 15 or 20 years to develop after a live birth. So may I now invite Dr. Geeta to take the discussion forward on the study design of this paper.
Yeah. Hi, ma'am, and hi, good evening, everyone. So let me deal with the study design and the discussion points on it. Can I share the screen?
Yes.
Yes, ma'am.
No, you haven't stopped. It is
Yes,
still
ma'am. I'll just stop sharing.
Yeah.
So I do have only, few points to discuss about the study design in this paper. So basically the points I would like to highlight in this study as well as in any study. So how do we, go about in case of study design? So any paper, when we analyze, where do we go and look for the study design? So basically it would be from the methodology. So the points I would highlight here is how to identify the study design in a paper, and then what are the types of study design in general, which we usually see in research, and then whether this study design is okay for the study, or what about the other studies, whether the other studies is better than the present design. So let me go ahead. So as I said, how do you identify a study design in a paper? So basically we'll spot it from the methodology, what type. So there are different types of study. The study here, which they have used is retrospective cohort study. So others would be a prospective, and there are case control studies, then RCTs, then from RCTs, then we do have meta-analysis and systemic review, and go on. And from the methodology, we also get other information about the duration of the study and sample size. So coming to the study design, which is used here, which is a retrospective cohort study. So what is a retrospective cohort study and why it was used for this particular study? So basically it looks backwards and it studies the relationship between the exposure and outcome. So what is the exposure here and what is the outcome here? And what was the question which was asked for the study? So basically we want to analyze whether the use of fertility drugs basically causes childhood cancer. So there are different types of fertility drugs which we use and different types of treatment which we deal with fertility patients, whether these drugs causes an effect, so which would be a childhood cancer, which we were worried about. So basically we do have all information which has happened, which has occurred, but we need to analyze. So that is why we need to go back and then analyze about it. Basically, it uses a pre-existing secondary research data. So the data which was used here was based from the registry, that Danish registry, which was available about the fertility treatment, which was used for the patients and people who had cancer, basically childhood cancer. So what they did was, in this study, they almost categorized childhood cancer as like less than 20 years of age. So it was a long follow-up, basically. And what was, so how easy it is for a retrospective data and why it is used is like, we already have the data available. And if we want to look at particular outcome, analyze an outcome, that is exposure and outcome, when we already have a data readily available, the easy method would be retrospective. Whereas in a prospective study, what we do is we don't have the outcome. We, with the risk factors, we need to analyze and follow up the patients and then go for an outcome and study the outcome. And with the retrospective, the resources, with the available resources, less resources, we can analyze the data. And the cost also, like when we follow up for a long time, maybe the cost would be more. Here, the retrospective, the cost might be less. All these points are when we compare to prospective, basically. And the other point is, when any study where a clinical trial is not possible, in that place also a retrospective study can be done. And in this study, so as I said, for childhood cancer, patients were followed for a period of 20 years. That is, from the registry, they've categorized up till 20 years and followed the patients. But whereas if this study would have been thought in a prospective way of thinking, like going ahead with a prospective study, it would have been tough if at all they follow the patients for a period of 20 years, number one. And the other thing is, as Dr. Aishwarya was telling about the limitation of the study, the first limitation was the group of patients which were, which they were looking for childhood cancer was less. And if at all we have to deal with particular cancer and look also, it would have been tough. So it was though it was like a gross area, they looked for a childhood cancer, and it was, they were able to get a few numbers. That was also a flaw here at the end. So this was a small subgroup analysis at the end when they looked into. So in retrospective analysis, we also do get some information which is usually unexpected also. And as in case of prospective studies, where we take consent, in retrospective study, informed consent is not required. So that is one thing. And is this okay for this study? And we will be able to answer to that question only when we know about other study and whether this study can be performed in other methods. Like for example, like where we have to analyze case control, we don't have the outcome here. So here, if at all we have to do case control study, when we need to deal with, see, this fertility drugs when we give for this patient, whether this patient is going to have this cancer or not. So it is not easy just like that to give a drug and to wait and watch whether this patient will be getting this cancer, or this fertility drug is not give them a drug which is not causing a cancer. So that was not easy. So case control may not be dealt in that way. And as I said, prospective, if at all we have to look in for cancer where like less than 5 years. So basically when children getting cancer within 5 years, maybe prospective would have been easy. So period of 20 years would have been tough if at all we have to see in that way. And what is meta-analysis? Meta-analysis is actually a compilation of data for the evidence. So whatever data is available, whatever studies are available in this particular topic, we need to compile and then look for the evidence. So as we know the hierarchy of studies in research, we know the studies which score well is meta-analysis. And then like meta-analysis, systemic review, then RCTs, and then comes case control and retrospective. So just because the study is a retrospective cohort, the question is whether we can rely on the study or not. See, the question, the answer is not that no, because there are few studies which have been done in retrospective way, because few studies cannot be done in prospective. And when we do have lots of retrospective study, and then maybe that would be an eye opener for more studies to come up, and maybe we can have other studies, and then it might score high later as when we collect data for evidence. So that is what I would say. And for this study, I think this is okay, because this was a long duration of, they followed up for 20 years. They did not follow up. Already the data was available and it was easy for us to collect information. So is there anything else I have to deal with the study design of this paper?
Yeah, thank you, Dr. Geeta, for that. So as you have said, it's a retrospective study, but it has got its own weightage because we can't get this data all across, in a finite time, and attribution of a risk is very difficult. So you cannot just attribute risk by 100 cases or 200 cases. You require basically a very large data. A retrospective cohort study may be an apt model to study a risk of, very rarely attributable risks. Like this is not quite common. Like what is the risk of ectopic pregnancy following ART in a triple fact? It's not like that. These risks are, we have our own doubts whether they exist. So we require larger data, and a retrospective model seems to be apt, as you were discussing. And moving on, we have Dr. Uma Satvik ma'am again to discuss one key statistical concept used in this paper, because this paper, as Dr. Geeta was discussing and Dr. Aishwarya was presenting, involves a lot of hazard ratios. So maybe Dr. Uma ma'am will highlight more on that, and how reliable, how we can keep this information for a future practice. So Madam is going to discuss on one key statistical concept used in this paper.
Yeah. So I can't seem to, first of all, okay. Can you still see my screen?
Yes, ma'am. Yes, ma'am. Your screen is visible.
I need to.
The desktop view is presently there.
Okay. Wait. Okay. Okay, this is always such a tough thing. I'm going to do it again. Yeah, so could I have Aishwarya unmute herself? I hope she's there. Aishwarya, are you there? Okay, never mind.
Yeah, Dr. Aishwarya is there.
Okay, can you
Dr. Aishwarya,
unmute yourself? I might just want
Yes,
you
ma'am.
to. Yeah.
maybe she has a problem of unmuting again, as I had the problem. I'll just call Himanshu if that
Yeah,
should be a.
I think she is able to respond. Aishwarya,
Yeah.
this is the paper you presented. So what did you find in this paper?
Ma'am,
Just your key finding, the one key finding that you had.
ma'am, that there was increased risk of, ma'am, ma'am, am I audible properly?
Yeah, now
You're
there is no
audible?
echo. You can, you are good. You're good to.
Hello?
Yeah, go ahead. We can hear
Hello?
you, Aishwarya.
Okay,
So
ma'am. Okay. I was not
the
able to
one
hear.
key finding.
Ma'am, that that in children who were born through frozen embryo transfer, there was an increased risk of childhood cancer, and the hazards ratio for that association was increased.
Increased. Okay. Now, why do you think this is happening? Do you think it is frozen embryo transfers, or is it, would you look at any other factor? Would you only look at the exposure and then you'd look at the outcome?
No, ma'am. Actually, whenever we are designing a study and we are trying to look for an association between an exposure and an outcome, we also need to consider factors that are not that are extraneous and affect the exposure as well as the outcome independently. And these factors are known as confounders, and we have to balance them while making the design of this study.
Okay, that was for me to discuss. I just wanted you to use your discretion to think about, do you think that the cancer risk is genuinely due to ART? Is it possible that it could be due to underlying infertility? And is it possible that this could be because of the couple factor per se? Or is it because of some perinatal factors that appear because of early delivery, preterm delivery, multiple births? Can those lead to childhood cancer? So we know, for instance, a parental history of cancer could lead to cancer in the children. We know that maybe a history of smoking, one doesn't really know. We do know smoking leads to a certain kind of cancer, which is lung cancer, but we're not sure if it leads to childhood cancer. So you might want to also explore that option. You also know that as parental age increases, there are risks of all kinds of problems, including epigenetic problems you've known of. And since there has been a link between epigenetic problems and cancer, as in the causative thing has been known, has been put down as some change in the epigenetics or the expression of the embryo, there we kind of understand one doesn't know if this is because of parental age. So when you look at it as a subject expert, when you have to ask yourself the question, when you find an association, is this true? Is this really the case? Is it FET that is leading to this? Could it be couple factors? Could it be underlying infertility? Unexplained infertility perhaps leads to a higher incidence of congenital anomalies. Male factor infertility, we know, leads to a higher incidence of congenital anomalies, specific kinds. And elderly women, advanced age women, leads to a higher incidence of congenital anomalies. So is it underlying infertility? And then finally, is it the perinatal factors? So when you have this broad view of what possibly can go wrong, you are already talking and thinking in terms of a confounder, right? And confounder, as you have probably already read, it's not a new concept, is a factor that is individually affecting the exposure and it's individually affecting the outcome, thereby not letting you know whether whatever association you have found is actually true. Is it being masked or is it being amplified? which is why you need to consider all this, right? And this is the job of you. Even if you were a reader of this paper, you have to ask that question. Or if you were researching that question yourself, this is something that you have to generate. What are the other possible reasons why my result might come out like this, right? So now this is what the authors did. They kind of divided it. So they were already trying to investigate the exposure, which is fertility drugs / ART. These, what you see in the middle two panels are the exposures they were trying to study with childhood cancer. But those two also they tried to add, which are couple factors and perinatal factors, and how do they really try and look at this in your study. First of all, you have to see that it is easy to get data on ART through centers, right? Your center keeps it, my center keeps it, everyone who's joined the webinar today probably have softwares to maintain ART data. And if we are looking at treatment year, fresh frozen, whether clomiphene was used in ART, gonadotropins. But what happens when ART has not been done? Do we keep an equally meticulous records of IUI? No. Do we keep a record of the the prescriptions that we give and what happened to those babies? And then again, do we follow up these babies all the way till 20 years or 30 years? If you and I had to conduct this study, we would have to really come together, first of all, and look at data that we don't have yet. It can only be in that sense, a data that has been prospectively collected, and maybe the next generation 20 years down the line will be able to come out with some inferences. But when you are looking at something this large, Dr. Geeta has already said, rare outcome, not just rare, but an outcome that develops time, retrospective cohort, perfect design, except that where is this data in our practice? We don't have it, but these guys did, right? And so they tap into 4 different registries to create what is known as the Danish infertility cohort. One is the National Population Registry, which gives you a timeline of birth, when it happened, the gestational age. Second is it has an IVF registry, which it maintains since 1994 very meticulously. So you know whether this was IVF, whether this was ICSI, whether this was frozen embryo transfer versus whatever. And you have the National Prescription Registry, which is, again, it defies all imagination. So they actually have a prescription registry which has been issued to people where, so they assume that if medicines have been given, they'll be given for 3 months, which is how it is, clomiphene or letrozole, and that women would have used it, which they identify that as a shortcoming. But here, at least they have the records to say this. They are not going on patient recall. So patient recall, when you collect data, let's say 5 years or 7 years later, and you ask them if this baby was born through treatment of infertility, they may say, okay, I did take it. I'm not sure if I can remember this, that in this pregnancy I took it or not, right? So here you are using records. And why I bring this whole thing up, and then of course there's the National Cancer Registry, is because here the study is relying on records and not recall bias, as is likely to happen in a retrospective study. If you have records, that is a very objective way of collecting data. And because of this, they are able to use very accurate definitions. What are those definitions? Children conceived after ART, 14 days before or after ART treatment. So they have the dates. This is the date when it has been done. They have the gestational age, and they can calculate that. Children conceived after infertility treatment because of that prescription registry. And this is 12 weeks after a fertility prescription was prescribed. And if the conception date fell within that 12-week period, they are considered to be exposed children. And then children conceived to fertile women is the control cohort. Outcomes are childhood cancer, any kind, with pathology diagnosis developing by or before 18 years of age, right? Now, once you have your definitions, you define your study cohorts and study. So we're talking about a retrospective cohort study. So they have 3 cohorts because they are trying to see whether infertility per se has a separate influence, or whether ART has a separate influence. And the control group is children born to fertile women. This is the control group. And then you have children born to women requiring fertility assistance, but you have within them, you have A and B cohorts. A is that group that conceived where the index pregnancy was conceived with treatment, and you have a group where the index pregnancy was not conceived with treatment, right? That identification was more or less accurately possible because of the four databases I showed to you. Now, the follow-up is for 4 to 18 years. Why is it not 18 for everyone? Because some children developed cancer early and some developed it late. So, and this is important for you to understand. When you're following up, this duration of follow-up per person would be required for you to be fed in your Excel sheets. Why? Because when we come to the definition of incidence rates, you will be asked about the number of years of follow-up. You would need that. So even though the study is conducted over 16 years or what is it? It's 16 years. Yeah, the follow-up is 4 to 18 years. Now, what are the outcomes studied? And these could be completely new terms to you: hazard ratios, incidence rates, and incidence rate differences for any childhood cancer. Now, I will go about talking to you first about incidence rates. What are they? Incidence rates from your PSM, if you try and recall, is the development of a new outcome over a unit of time, per year or whatever. So if you remember TB cases that we would read, there was a word prevalence that we would use, which was all the possible TB cases, old and new, that you see in a year. And incidence was the new cases of TB that were seen in a year. So in this particular example, we are taking the definition of rate at which an outcome occurs per unit time. It is used to indicate outcome for time to event variables. Now, I don't know if you've attended some of our previous webinars, but there are three kinds of variables. One is a binary or a categorical variable. Categorical variable is one example of categorical variable is a binary variable, like live birth is a binary variable. You either have it or you don't have it. It's a yes or a no outcome. Then you have a numerical variable like age, like you have AMH and all that. In this case, when I say, and there's a third variable, which is a time to event variable, which is a hybrid variable. It has a categorical component or a binary component, and it has a numerical component. So when you're dealing with rare outcomes and when you're dealing with outcomes that happen over time, you use the variable which is known as time to event variable, right? So, which is whether that outcome occurred or not, and the number of years it took to get there. 4 years, 10 years, 18 years is how you record your outcomes. So the denominator of incidence rates is a little weird. It's not the total number of people. It's the total number of people followed up for a certain number, for the number of years that outcome either developed or the study ended. So if it ended 12 years or 18 years later, that's where those are the number of years that you follow up, right? Now, so incidence rate difference and incidence rate ratios are two outcomes that are derived directly from incidence rate. You don't have to do much here, not much of thinking there, but incidence rate difference is just the difference in the incidence rate of outcome between exposed and the unexposed group. And incidence rate ratio is the ratio of incidence rates between exposed and the unexposed group, right? So I'm just going to take a detour to this WHI study, the Women's Health Initiative study that you and I are very well versed with, right? A study undertaken in 2002 had dramatic results with respect to the outcomes that it was showing, but the outcome that it uses is incidence rate difference. And so that's just an example of what we've just been talking about. So it talked about the usage of oral estrogen and oral progesterone in women who were menopausal and given treatments for as long as even beyond 63 years of age. And they found that HRT use in menopausal women would lead to 7 more CHD. So that's the difference that you calculate from CHD incidence in women on HRT versus CHD incidence on or in women without HRT. And the denominator is per 10,000 women years. You could choose to have 100,000 if your outcome is rarer, or 100, or per women year, also depending upon how rare your outcome is, right? Hazard ratio is again, I don't know if you know of regression, but regression is a way of adjusting for confounders. There are different kinds of regression analysis. For a time to event variable, when you're trying to adjust is where you're trying to eliminate the effect of confounders by taking them into the equation, but by using sort of, it's a difficult concept to grasp, but understand that you have they are there in your equation. You have considered them, but what happens if that outcome was not varying? If it was standard, then how much would your incidence rate be is what hazard ratio determines. And the term used is Cox proportional regression analysis. We are not going to go into the details of this. So quickly, incidence rate is number of events per person years happening. Person years is number of people multiplied by number of years of follow-up. And hazard ratio is adjusted incidence ratios calculated using Cox proportional analysis, right? And these are the results. We are going to quickly go into just, for instance, you can look here. These are the number of children, 910,291. These are the children born to women who did not have infertility problems, so fertile women. And when you add the number of years that they were followed up, these are the person years of follow-up. So this comes to 10,385,749 person years of follow-up. How many cancer cases? 1876. How do you get your incidence rate per 100,000 persons? This is the numerator and this is the denominator. So you get your incidence rate per 100,000 people, right? Now, not very difficult to calculate incidence rate difference per 100,000 person year. Why? Because this is the baseline. Cancer rate in children born to fertile women, 17.5 per 100,000 women per year is the baseline. In women who were infertile, the number of cancer cases, 341, absolute number is of course fewer, but when you divide the numerator by the denominator, you get 17.6, more or less the same, and 17.6 minus 17.5 is 0.1, that's the incidence rate difference, right? So you know that this is not very high, but I'll quickly look at the confidence interval, which crosses 0 on both sides, -2 to 2.2, which means that it includes a 0 in the middle, so it's not significant. So this is the statistics part of it. We'll go into what the results further said. So when you compared fertile women with infertile women, actually there is no difference in cancer risk. But now they are looking at what happens when the mother, infertile women, remember there are two kinds. There are women who did not receive treatment, which is about 70,000 babies, and yet conceived spontaneously. And we see examples of that all the time. And there are 19,000 babies being born to infertile women after treatment. And this treatment could be medicines, it could be ART, it could be IUI. So those are the clubbings that have happened. And so they want to do an analysis because something within their statistics, there was that likelihood ratio that that was mentioned, but I'm not going to go into there. So something within there that said that you need to do a separate analysis to look at the effect of these independently, right? So what happens? Okay, we have done this. I'm not going to go there. So they do a drug analysis, and drug analysis, like I said, if I have to only look at the results, I'm not going to explain this. I'll go to incidence rate difference and I'll see that all these figures here, and I'll look at the confidence interval, and none of them, all of them seem to include a 0. So it's on this side of 0 and on that side of 0. So nothing here is significant, and they are studying gonadotropins, clomiphene, SIG, progesterone, estrogen. So nothing happening there. What happens when they go to ART? ART is when things start to change. You can see the incidence rate is 17.1 for in vitro fertilization, which is the same as your baseline. Your baseline, if you remember, was 17.5. So actually the incidence rate difference is minus 0.4. Again, not significant. ICSI is 23.1. FET is 44.4, which to me, it seems like a 2.5 times higher rate, and others are unspecified, but the treatment was not known. It's too small to calculate, right? So how do I know if the confounders here are not working, right? This is the pure incidence rates based on just these numbers divided by the person here. Now I go to hazard ratio, where they put in the covariates, where they are trying to balance the confounders statistically. And this is what they come up with, a 2.43 hazard ratio figure, which is almost a 2.5 times increase in the risk of childhood cancer when a frozen embryo transfer is undertaken. Here, although you see 0.96, 1.33, but this is not high enough. It's not significant enough. So we'll just let that be. Okay. So this is how you interpret hazard ratio, incidence rates. And because they were also interested in whether this is underlying infertility or no infertility. So they can make this comparison between ART treatments versus women with infertility but no ART. And the effect remains. The effect hazard ratio is still equally high, slightly reduced from 2.45 to 2.35. Confidence interval still remains high. And so they're able to make those conclusions, right? So I'll just end this here because Dr. Rita is not here, and I've taken sort of that time to explain incidence ratios to you, which she was supposed to do. Anyway, so what have we learned? Rare diseases developing after long follow-ups require a huge sample size, and this is met best by retrospective studies. Data collection in retrospective studies can suffer from recall biases, but can be overcome by records or record linkage. This study is an example of record linkage. Confounder identification is essential in retrospective studies, best done by a discerning researcher. Being aware of confounder balancing methods is desirable, right? Thank you so much.
Thank you very much, ma'am. That has been very nicely explained. So I think all the viewers will be highly benefited because they're clarified with how to take the results from the retrospective study and how to, when the retrospective studies are, deemed more appropriate, and what are the types of hazards we are dealing with as we have looked at in this study, how frequent they are, and all this were very nicely elaborate. Thank you very much. That's very detailed one. So moving on. So we will go with the second paper. The second paper is a randomized controlled trial, which is effect of timing the endometrial receptivity testing versus standard testing of frozen embryo transfer on live birth in patients undergoing in vitro fertilization. And it's an RCT published in JAMA. So we have, once we are all started believing ERA, and we are timing all the transfers, and some people start using ERA routinely. And then they have come, the later evidence which has come largely disproved or largely put down the ERA. We are all aware, and now we're not, today. RCT probably would throw more light on way to keep this endometrial receptivity testing in the present day clinical practice. What relevance has it got? Has it got a relevance at all? So we have Dr. Deepti Pachauri. She is an IFS fellow in the reproductive medicine from Nova IVF Delhi. And this paper will be discussed by Dr. Garima Kapoor, ma'am, following her presentation. Yeah, Dr. Deepti Pachauri, she can take over.
Thank you, Dr. Siddharth. Dr. Deepti, you can start your presentation now.
Good evening, ma'am. Ma'am, am I audible now?
Yeah, yes, you're audible. You can start sharing your slides now.
Ma'am, should I do share screen?
Yeah, please do. Please share.
And what to do next? It is showing
You share
entire
screen. Go to the share screen option.
Can't tap on that.
You want me to share it for you?
Yeah, sure, ma'am.
Okay, I'll do that for you. So, starting, I hope you can see the screen now.
Yes, ma'am.
Okay, start, Titi. I'll scroll it for you.
Yes, ma'am. Good evening, everyone. Am I audible to you, ma'am?
Yes, you are audible. You can
Yes.
continue.
So, the article is the effect of the timing by endometrial receptivity testing versus standard timing of frozen embryo transfer on live birth rate in patients undergoing in vitro fertilization, a randomized clinical trial. The rationale of the study, the endometrial receptivity testing is purported to improve live birth rate following frozen embryo transfer. There is no biomarker that has been demonstrated to reliably predict endometrial receptivity. The available data, whether to perform endometrial receptivity testing routinely before embryo transfer, is conflicting. And there is no adequately powered RCTs using only euploid embryo and accounting for the potential positive effect of endometrial biopsy on uterine receptivity. So this is a outline of the article. The question is, does the use of endometrial receptivity testing to time transfer of a frozen euploid blastocyst created by in vitro fertilization improve the chances of achieving live birth? The study is going to conclude that this clinical trial found no statistically significant difference between transfers in endometrial receptivity time group and in the standard timing group that resulted in live birth. The study included 767 females, and the mean age of the females was 35 years. The study was conducted at 30 different sites in the US. The participants, which were those who were included in the study, was grouped into two categories. The first one is the intervention group, which is receptivity time FET, in which the embryo transfer was done according to the endometrial receptivity timing, and the other group is the standard group, in which the embryo transfer was done at the standard timing. The primary outcome of the study was live birth rate at 23 weeks gestation or beyond. So the study found that there was no significant difference. As you can see that in case of the intervention group, the live birth rate was 58.5%, while in the control group it was 61.9%. So the difference was not significant. The objective of the study was to compare the live birth rate from the single euploid frozen embryo transfers according to endometrial receptivity testing versus standard timing. So in the methodology of the study, the ethical statement, study approval obtained from the Western Copernicus Group, institutional board, and the informed consent obtained from all the participants. The design of the study, it was a double-blind, randomized clinical trial. The study was conducted at 30 sites within a multi-center private fertility practice in the eastern US. The participants were enrolled from May 2018 to September 2020. Follow-up concluded in August 2021. The inclusion criteria was the participants were in the age group of 30 to 40 years, and they were likely to produce at least one euploid blastocyst based on their ovarian reserve testing. The inclusion criteria included all those participants in which either the sperm or the donor, either the egg sperm was surgically aspirated or the donor eggs were used. In case of recurrent implantation failure, in case of recurrent pregnancy losses, if there is any abnormal uterine activity, the BMI more than 40, if the participant were currently pregnant or currently lactating, or if there is any contraindication to the IVF. So this is the chart showing the recruitment, then the randomization, and how there was a patient flow in the study. Total 1887 patients were screened and eligibility criteria was seen, and on the basis of the eligibility criteria 909 participants were not recruited, and finally 978 participants were recruited, and they undergo in vitro fertilization, and the pre-implantation genetic testing for aneuploidy was done. Once the in vitro fertilization and the pre-implantation genetic testing was done, 187 participants were excluded on the basis of, number one, if there was no euploid blastocyst; number two, if the blastocyst, there was no blastocyst for PGTA; if third is if the patient, if there was a patient choice to be excluded from the study; if there was a spontaneous pregnancy; if the partner unable to produce semen specimen and there was no oocyte vitrification; and the last one, the loss to follow up. After this, total 791 patients were recruited, and those participants underwent endometrial receptivity cycle. And after that, again the 224 participants were again excluded, and finally 767 participants were there in the study who were randomized and was divided into two groups: the randomized to receptivity time frozen embryo transfer, and another group was the standard frozen embryo transfer. Once both the patients were randomized in their respective groups, the endometrial receptivity cycle was started. In the endometrial receptivity cycle, the exogenous estradiol was given, and when the endometrium was of more than equal to 7 mm thickness and the progesterone was less than 1.5 nanogram per ml, the progesterone support was given, either intramuscular progesterone 50 milligram daily or the intramuscular injection 50 milligram every third day plus micronized progesterone was given. Then the endometrial biopsy was done for endometrial receptivity 123 plus minus 3 hours after the first progesterone injection. Then after the receptivity testing, the timings of frozen embryo transfer. In the control group, the transfer was done at the standard timings. In the intervention group, if the test says that the endometrium is receptive, the transfer was done at the standard timing. If the test says it is non-receptive, then the transfer was done as per the ERA result. So these are the three outcomes. The primary outcome was the live birth rate at 23 weeks or beyond in both the group. The secondary outcome was biochemical pregnancy, clinical pregnancy or ongoing pregnancy. And the post hoc analysis included biochemical pregnancy loss, clinical pregnancy loss or total pregnancy loss. This is allocation concealment. Endometrial receptivity cycle results were received only by the study coordinators. The sample size calculation, a priori sample size calculation estimated that 748 participants completed per protocol would provide 80% power to test the null hypothesis of no significant difference in live birth in two groups. A 5% dropout rate was anticipated, attributable to unavailability of euploid blastocysts. The statistical analysis, dichotomous outcome were compared by the chi-square test. The post hoc subset analysis were performed using the R statistical computing system. A two-tailed p-value less than 0.05 was considered statistically significant because of the potential for type I error due to multiple comparison. Findings for analysis of secondary endpoint should be interpreted as exploratory. So these are the results. First, the study participants in both the groups were compared, and you can see the mean age of the participants in both the group was around 35 to 37. The BMI was comparable. The history of previous live birth was comparable. The history of failed embryo transfer were comparable. and most of the participants got the day 5 embryo transfer. So this is the endometrial receptivity biopsy results in both the groups. In both the groups, the maximum maximum result falls into the category of the non-receptive, both in the intervention group, that is 211, and in the control group, that is 208. Get the next slide. So this is the transfer result, including the primary outcome, the secondary outcome, and the post hoc outcome of the randomized participants. When we look into the clinical pregnancy loss, it was if we get into the primary outcome, that is the live birth, it is comparable in both the groups. In the intervention group, it is 58.5%, and in the standard group, it is 239%, with a ratio of 0.95%, and the p-value of 0.38, which is not significant. Again, if we look into the secondary outcome, that is the biochemical pregnancy and the clinical pregnancy, in both the categories again falls into the p-value of 0.48 and 0.25, which is again non-significant. If we look into the post hoc analysis outcome, that is the biochemical pregnancy loss and the clinical pregnancy loss, there is a slight difference, that in case of the intervention group, it is the biochemical pregnancy loss is 29, and in the standard group, it is 25. And can I get to the next slide? Yeah. Ma'am, can I get to the next slide, please?
Yeah.
Yeah, the post hoc analysis, when the endometrial receptivity testing recommended to change the time of transfer for more than equal to 24 hours in case of the biochemical pregnancy loss, and if we compare the biochemical pregnancy loss in the intervention group and the control group, the p-value came out to be 0.02, which is significant, which shows that in the intervention group, if we do the adjustment of the embryo transfer according to the testing, there is the more biochemical pregnancy loss. And so in yes, ma'am.
Yeah.
And again, in the category of the clinical pregnancy, the p-value came out to be 0.01. That means in the intervention group, the clinical pregnancy was 76. If we change the timing of the embryo transfer according to the receptivity testing, and in the standard, it is 94. So basically, if we are going through, if we are going like the standard transfer, the clinical pregnancy was 94, and if we are changing the timings of the embryo transfer as per the receptivity testing, the clinical pregnancy was just 76. So among the patients for whom IVF yielded a euploid blastocyst, the use of receptivity testing to guide the timing of frozen embryo transfer compared the standard timing for transfer did not significantly improve the live birth rate. The limitation of the study was the patient with recurrent implantation failure and the recurrent pregnancy loss were excluded. 15.7% of the planned participants were withdrawn due to not having a suitable embryo for transfer. The study was not powered for analysis, limited to the non-receptive subgroups. So in the end, we conclude that in case of euploid transfer, the use of endometrial receptivity testing did not significantly improve the rate of live birth. The relevance being the findings do not support the routine use of receptivity testing to guide the timing of embryo transfer. Thank you, ma'am.
Thank you, Deepthi. This was indeed a very interesting study, and it did change our outlook towards ERA. And suddenly we realized that, yeah, maybe this is not something that we are looking forward to when we are thinking. Now, with this, I would like to go to the statistical concept of study design. I'll just need 1 minute while I just try to change it. Just give me a moment. Yeah, okay. So here now I want to, with this was a very good study, and with this I want to take out the concept of randomization. So why do you think randomization is important, Deepti? What do you understand by randomization? Why do you think it's important?
Ma'am, so that there is no bias in selecting the patients in a particular control group or the intervention group.
Okay. So like, what do we understand when we say that we want randomization? Basically, we think that it is the gold standard. We all understand gold standard, but really what is it? Let's say I have these gum balls and I have to color these gum balls, and I randomly do color the gum balls. So by the end of the day, what I'm getting is gum balls. So do you think it really makes a difference? But yes, for us in a clinical trial setting, in a medical setting, it does make a difference because we are putting an intervention. So these are our patients, and we are assigning them randomly to different interventions. And yes, with different interventions, we expect a different outcome so that we can actually compare. So talking about, yeah, just a okay. So talking about randomization, basically you are randomly assigning participants to group that receive different treatments, because as Dr. Deepti has said, we want them an equal chance of receiving any treatment, and we want to make an unbiased and informed decision so that when we come to a conclusion, it is because of the intervention and nothing else. So that is the sole purpose of doing a randomization. So you are eliminating the selection bias and you're giving everyone equal treatment. And therefore, one treatment is compared and gold standard, because yes, if you want to get your article published, we know it has to be a randomized trial. And this is it. So was there any disadvantage, or is it everything is good and fine? So they say the result may not reflect a real life situation. A very apt example from the current study. Now, current study talked about euploid blastocysts in women who did not have any recurrent abortions. But these are the kind of situations we get. We may not end up getting good blastocysts. We may not end up getting patients with bad obstetric history. So this is not actually what is the real life situation. One. Secondly, there is it all right to randomize on probability rather than on the support of medical judgment of a medical professional? Again, a big question mark. And these trials definitely are more expensive because, as Madam Dr. Geeta had also told you in the previous one, that you have other things which are less cost effective. Obviously, RCT is the standards, but yes, with the good quality evidence, you need to add the price to it. Now here I'm going to talk about different types of randomization, or what are the different type of randomization, just to get one is simple randomization, block stratified, adaptive, and minimization, which I'm not sure is part of randomization, but I thought I'll introduce the concept. Now, what is simple randomization? Simple randomization is you can flip a coin, you can roll a dice, you can swap your cards, anything you do. So basically, you are generating a random sequence, a single sequence of random assignment. It is the most easy, simple, and easy way to do. And definitely good for large clinical trials where I want to get it. You can even use your random generation tables that are computer generated. Again, if you're going to detail, they're pseudo or proper, but we leave that aside. But yes, you can do that. But the problem is you can't do it for small clinical trials, because when I'm randomly generating number in small size groups, we don't know whether it will be balanced because of the small number. And if your recruitment of participant is ongoing, therefore there can be inaccurate result between the treatment and participants group in different groups as they are enrolled over time. So if it's time dependent, you may not have an equal distribution. But yes, a simple and very commonly used for large. Then the next what you have is the block randomization. Here you keep a sample of each group similar. So you divide it into blocks, but the thing you have to ensure is that they are equal, and then you can further do it. Block randomization, again, your blocks may not be representative and there may be difference, and there may be certain selection bias added to it. Like suppose if you're doing a center on ART, so you can have different ART centers as block. That is something you can do. But again, here again, because you have a different centers or different blocks, the population it caters to, the kind of patients you get, there can be a difference, and a selection bias inherently may come in. So basically, when you're dividing into blocks, the principle is it has to be equal number. Usually you multiply by a group, so your blocks have to be even number. We prefer small size blocks and equal number. And they are randomly selected to sort the participants into group. But again, as we said, because different blocks may have different features, so selection bias is more likely to come in. Then you have the stratified block randomization, basically what we call as the stratified randomization. What you do over here is that you're selecting your patients depending on their certain characteristic. Like a simple would be, if I have to do a study on ART, like for these euploid blastocysts, I could do it for PCOS patient, I could do it for POR patients, I could do for male factor infertility. So here I'm stratifying it according to different variables. So I'm dividing them according to a particular feature of the study. Okay. So that is your stratified randomization, and you can further stratum according to the different groups, as you can see in this. So again, you are separating upon certain factors, which could be gender, which could be particular clinical. This reduces the imbalances and characteristic found in treatment group and increases the statistical power. And it is easier to generate blocked randomization lists for different prognostic factors. Like I said, if you go on to the type of infertility in unexplained different PCOS, POR, you can divide it according to that. But again, you have to remember that the groups won't have the same important characteristics, and when you're interpreting the result, they may be different characteristics of your group that you are doing. Then comes the adaptive randomization. Now, what do you mean by adaptive randomization? Basically, what are we fixed to? We are in tune with the fixed clinical trial design, that I start with a treatment group and I start with a control group. This is my original planned sample size, and we go ahead with a final analysis. But this is not what happens in reality. A very good example was this article itself. So what are the ways in which you need to adapt your clinical trial as it progresses? One is the sample size reassessment. Like you can start with one treatment and standard of care and assign a different sample, and you may have to increase. Like in this study, a very good example was that they started with 746 participants and they expected a dropout rate of 5% because they were not expecting to get euploid blastocysts. But the study started in 2018, but in May 2019, they discovered that the dropout rate was much higher. It was more than 5%. So they increased their study participant to 975 participants to ensure that the adequate power is there. So this is something like you need to adapt. You may need to increase your sample size. So this is just a very good example of sample size reassignment. The other is that clinical trial with response adaptive randomization. Say you're giving one treatment to other, the other standard treatment to other, and you are seeing an obvious benefit of treatment on one side. Like in this case, had the study gone further, let's say if it would have reached the statistical evidence that your standard of care, like your ERA is, as you had seen in her charts, the clinical pregnancy rate with ERA was less than the standard transfers, though it did not reach statistical significance. Had it reached statistical significance, you could have increased your size, you could change your sample size. You may have considered changing your sample size towards the one without ERA. So that then you may have to allocate to a favor enrollment to treatment group. So that may also have to be done. So this is adaptive randomization, something which can be used. So here again, the allocation is changed according to the progress of the clinical trial, and this minimizes the imbalance between treatment group and can adjust the treatment group depending on the effect of treatment has on participants. And the prognostic factors do come to play and role, and the treatment influence also has a role on this. Then this concept of minimization, this is not exactly randomization, but another way in which you could divide is basically if you want to balance out the prognostic factors, first you allocate a treatment group using simple randomization, and then you are assigning a control group in which you're balancing out all the prognostic factors based on the previous. Okay, but this is, I don't think it's a part of randomization, but another method of study. But again, we need to come to the ethics of randomization. Basically, again, the big question is we are determining the treatment for our patients based on probability and not on the wisdom of medical professionals. And obviously, there are risks to clinical trial. Like in this case, if you say, if you're doing an ERA and if you're clear-cut getting a decreased clinical pregnancy outcome and still you're subjecting your patients to that. So that again is an ethics was always there. And yes, sometimes your patients are not given the full picture, and again, which could be there. Thank you. So with this, I would like to invite Dr. Mohan Kamath, sir. Yeah. So sir is the head of the reproductive medicine at CMC Vellore, and sir will taking up the next statistical concept. Welcome, sir.
Hi, Dr. Garima, Suma, and everybody. So, I was just thinking, okay, so this is a trial on ERA. So, and I thought I will just take the participants through a very important concept called ITT analysis versus per protocol. And it's not too heavy in terms of statistics. It's just a couple of examples, and I think that should make us understand. So randomization is basically what we are doing is we are trying to have a 100-meter race. You know, we know the 100-meter race where all the participants start from the same baseline. Unlike 400 meters where they start at a different line because of the circle. So we don't want to start a 100-meter race the way we start the 400-meter race. Essentially trying to say that no group should have an undue advantage. And the undue advantage here is some favorable prognostic variables in one arm, you know, it is skewed. So one group of participants, because of random chance, ends up having a lot of patients with good prognosis, whereas the other group does not have so many patients with good prognosis. Randomization is trying to do that. It's trying to balance that and trying to get all the participants, be it in the intervention or in the control, at the 100-meter baseline, so that no participant has an advantage or no group in the trial context should have an advantage when they start. So briefly, what intention to treat analysis means, and it is the way the analysis has to be presented. That is, we have a primary outcome, and the primary outcome in the ERA study that was just read out is live birth rate. Remember that the primary outcome is on what we actually base our sample size. So that's why it's called the primary outcome, and that's of interest. And your conclusions of the study will be based on the primary outcome. So here it was live birth. So what we are looking at is when we say we are going to do an intention to treat analysis, what we are trying to do is we will account for all the participants who were randomized. That is, in the denominator, let's say 100 were randomized, each arm, you will have 100 at the denominator for both the arms, and you'll just count the number of live births that happened during the trial in each of the groups. That's all ITT is. And this is, I will give you an example if it's not very clear, but essentially ITT would reflect the real life world, you know, real life practice. That is, many times your patient will drop out, they will be lost to follow up, or while they're waiting for IVF, they conceive very often. And that's a very routine story for us. So you would have randomized for reasons beyond what is mentioned. They will simply not be there till the end of the trial. So these are all dropouts or attritions. But in ITT analysis, we will count them for the final analysis. You will not take them off the denominator. That's a simple message for this particular concept. Wherein the other one, which is the opposite of ITT, is per protocol analysis. Per protocol is that denominator is only those participants who stuck to the protocol. That means that if an ERA was done and everything, right from randomization, they had the euploid blastocyst and the ERA was done and they stuck around and you had the live birth outcome. So all those who did not turn up for after randomization or dropped out will not be a part of the denominator. And that's per protocol analysis. So put it simply, per protocol generally is more closer to the effectiveness in an analysis. Why these concepts are important, I will give you an example on this. So I'm using the same trial, and you can see here that I have highlighted 381 were randomized to ERA and 386 were randomized to the control arm. And you can see drop down, some were for various reasons mentioned. So transparency is maintained, which is very important. And you have 375 and 380 finally per protocol. So remember these numbers. And now I will show you what the authors have done. So you can see here that in that chart, they have actually included all the women randomized, 381. So this is an ITT analysis. And you can see here the number of live births in one of the arms is 223, the other one is 239, 69, 61. So their intention to treat, and this is the first results they have put in the paragraph. If you look at the results section, I've highlighted here, the live birth rate was 58 point, whatever there in the table. Now you can see one more line here, which I've highlighted. They go on to inform us about the per protocol results, which is similar. So that's a good thing. 58.7 versus 62.1. Usually the per protocol analysis in positive outcomes will be higher than intention to treat because the denominator usually shrinks many times. So that's why you have higher pregnancy rates, live birth rates you can see here. So this is very important. And why it is so important, I will show you. So there is another trial which was published some 8 years back or 7 years back from the group, Carlos Simon group, which got published in RBM Online on ERA. And what they did, you can see here, you can see the flow chart, and you can see the number of patient participants in ITT analysis is almost half of the per protocol is almost half of ITT, 141.80, 148.90, 145.94. And that is a huge problem, which probably the authors realized. And essentially, if we get to review this paper, it will raise serious concerns about the validity of the results. And that's what happened. And surprisingly, the authors go on in the abstract, and their main focus is per protocol analysis. So you can actually, I don't want to read out the whole abstract, but it's available online free. It's an open access article. And you can see that they had a dramatic 50% dropout even before the trial launched. And subsequently, they had huge dropouts. But they go on to conclude, based on per protocol analysis, that there's a significant improvement in pregnancy and cumulative live birth following the ERA. And this is a bit of a surprise because normally, methodologically and with reasonable caution, most of our editors would not allow this to happen. And you actually go down and check the ITT analysis, and the results of ITT analysis are bold in the last line, which is cumulative live birth or per embryo transfer. There was no significant difference in the primary outcome. So the live birth you can see for ERA was 40, fresh was 44, and there's no different 34 without ERA. Cumulative was 62, 55, and 58. So no significant difference. So ideally, they are supposed to base their conclusions on the ITT analysis, but they went on to do it on per protocol. And that's why the trial that was presented today was published in JAMA. That is one of the highest impact factor journals because it could withstand the scrutiny, whereas this particular trial, for reasons it's quite clear, could not withstand that kind of a scrutiny. And final point is intention to treat analysis is the preferred analysis. Per protocol includes only those patients who adhere to protocol. So a lot of dropouts will be there. The problem starts when you have a difference in ITT analysis versus per protocol. And that makes it a tricky situation sometimes to interpret. But those who believe in and are purists in terms of methodology would definitely base their conclusions based on the ITT analysis. And I think it's important that we all have these basic concepts clear when we read articles, because many times the way it is presented can really confuse us. And that's why I believe knowledge is power. Thank you.
Thank you, Dr. Mohan. It was a very well-explained concept, ITT versus per protocol analysis. And with this, I would like to invite Dr. Umesh Jindal ma'am. Madam is a director of Jindal IVF and Research Center at Chandigarh, and Madam will be taking the next statistical concept. I'll just share the slides.
Uh,
Good evening, ma'am.
Dr. Kamath, I have one question.
Yes, ma'am.
Intention to treat, whenever we are randomizing, we have a number which are eligible for randomization.
Yeah.
And out of that, a lot of people would drop out and not participate in the study.
Yeah.
So how does that factor affect the outcome or intention to treat analysis? Still, I mean, see, you intended to include, let's say, in this particular patient, some 800 or patients, but finally could include 730 or although it's a very good number, but how does that exclusion affect?
That's an interesting point. And actually that comes to, I was looking at the flow chart and those authors have ducked one question where they have written that eligible but not recruited. That is the initial 1,800 I think they have taken off some 900 patients saying they were eligible but not recruited, but they haven't given reasons. And then they've gone down and then given the reasons for exclusion for certain group. But the worry is that if you have a lot of participants refusing or dropping out before randomization, we just need to see if there is some bias coming, and we call it pre-selection bias. Is there a particular group of patients who are not keen, and that should not introduce a bias in terms of those who are entering in the trial? There should not be any systematic differences between these two groups, the ones who have agreed to get into the trial and ones who did not. So the second trial which I mentioned, the Carlos Salmon trial, had almost 50% patient participant refusing or reasons they could not get randomized. So there is an element of pre-selection bias, we call it, but it is something that is a worry, but it's not a big worry as long as there's no pattern to it. So, but yes, there is an element, we call it pre-selection bias.
Thank you.
Yeah.
Just one question, Dr. Kamath.
Yeah.
The sort of ITT, the denominator is considered after you have randomized, right?
Yeah.
Or not? Okay. And the example you gave was of the group before randomization of pre-selection bias. Would you?
Yeah, that was pre-selection is before. That's not the randomization.
But that so here the denominator would still be the ones who were randomized.
Yeah, ITT is always all randomized.
Right, post randomization.
Yeah.
Right. Thank you.
I think we had quite a bit of discussion about bias and randomization. Dr. Garima explained in detail. So I will just take a few important points related to bias. Next slide, please. Bias refers to potential of flaws in study design, conduct, or analysis, which can lead to inaccurate or misleading conclusions, which may be far away from truth. Next, please. So, what are the implications of bias? Studies affected by bias can be inaccurate. For example, finding false positive or false negative effects or association by over or underestimating the true effect. This can in turn lead to inappropriate guideline recommendation or meta-analysis conclusions. Also, it wastes a lot of resources. It also lost opportunity for a meaningful conclusion from a study and effective intervention, or there could be harm to consumers. Next. Validity of the study or the quality of a study is the extent to which its design and conduct are likely to prevent systematic errors or bias. There are 4 potential sources of systematic bias in healthcare trials. There are well-defined tools to assess the risk of bias. This one is Cochrane Risk of Bias Tool, ROB 2.0 for RCTs. Then there is a Newcastle Ottawa scale for non-randomized studies and risk of bias in non-randomized studies of intervention, Robbins 1, and bias in study design and implementation. I'm not going to go into the details of tools, but I will just take example of the tool which ISHRE has given for guideline formation. So I will, just for an example, I will take that tool. Yes, next. Factors which influence the risk of bias are the study design. First of all, whether it is a meta-analysis, it's an RCT, it's a non-RCT, observational study, cohort study, etc. So, and the tools also vary according to the type of study. Then sampling method. How did you sample the like randomization and all that? And sample size and power, I think this is one of the very important factors which induces bias, that you do not have adequate power and power, and you just have some 20 cases, 30 cases, and try to conclude some answers. So usually, especially in small thesis kind of studies, your students are, for practical reasons, they cannot have huge number of patients. So a lower sample size generally is low in power to conclude data. And then data collection method, because most of the time the data, digital data collections are not there because digital records are not there. So it's mostly manual, data is collected manually. And if there are incomplete fields or incomplete methods are there, then again the risk of bias would be there. Then data analysis, what methods have been used for data analysis, and then finally the interpretation. Dr. Mohan gave a very good example of interpretation, that despite 50% dropout from after the randomization, still they interpreted that the results are very good based on protocol, not intention to treat, but protocol completion patients, they try to interpret the positive result, which is totally fallacious. Then funding source and conflict of interest are again very important. Like many studies are industry driven, and or the authors have taken they're attached to some companies, or they have taken some benefits from some companies. So they may be inclined to give a favorable interpretation on some. So declaration of funding source and conflict of interest is a basic requirement for all good papers. Then study duration and follow-up, whether it was adequate. Like in this study, the primary endpoint was live birth. So did we have a dropout in obstetric population? I think that, or whether they did follow up all the patients till delivery or miscarriage or something. So that's also a very important point. And then study duration for adequate recruitment. So this study was for 2 years, but it was done at 30 centers. So they could recruit adequate number of patients in this study. Otherwise, in general, 1 or 2 year studies with follow-up of especially infertility patient till live birth, 1 year study will not give you adequate number of patients, or will not be able to complete the protocol in most of them. Then the participant characteristics like age, BMI, etc., or other confounding factors like that may be there, which may not have been taken care of. Like in this study, they have taken they have excluded recurrent implantation failure, recurrent abortions, and things like that. And so the sample size is quite uniform. There could be one study where they have taken only the euploid embryo patient, where there were euploid embryos were available and endometrium was good. So in those patients, there would be some confounding factors because of the recurrent abortions or recurrent implantation failure. Endometrium is another confounding factor, which is usually not very specifically controlled. In these patients, they had specifically controlled for in one of the eligibility criteria was a good endometrium, and all known endometrial factors were either corrected or excluded. Next. Then how to avoid this bias? RCT is one method. So most of the times it's only the RCTs which, what qualify to be as to be good studies. Out of that, again, you have to see where there was a risk of bias or not. But other studies, observational studies, etc., they usually do not follow, or retrospective studies, they do not at all fit in for quality studies. Outcome measures have been well defined. Controls for confounders should be there. And registration of studies, one method where you can, ensure some uniformity in designing the studies. And funding disclosure has to be there. In this paper, I think I have seen one of the most detailed funding disclosures at the end of the paper. So that's also a very important source. Then some real world examples where bias can play havoc was one of the WHI studies. We all know about this study. The conclusion of this study almost wiped out all HRT treatment for menopausal women. And maybe we have avoided so many women who could have benefited from it. And even now it's very difficult to start HRT for any postmenopausal women. We have got such a bad scare, the public also and the doctors also. Then in infertility, we have a lot of studies for food supplements like DHEA, CoQ10, which are not of good quality, and ultimately you end up saying that because see, if you review any meta-analysis on these supplements, some meta-analysis will say there is an effect, some will say it is not effect, but the evidence is of poor quality. So you are nowhere ever. Because if the studies are not good, your evidence remains of poor quality and you don't get any conclusions. Scratching again, like ERA, scratching also came in a big way that endometrial scratch improves implantation. Again, a very good multicentric randomized RCTs, they have proven that it is of no use. Next, please. So types of risk of bias. There could be selection bias, which I think Garima took to some extent. Then performance bias, detection bias, attrition, reporting bias, funding, conflict of interest, analytical bias, information bias, and publication bias. We'll take the tool and try to answer these questions for this study in what we are discussing. So an appropriate method of randomization was used to allocate participants to treatment groups, which would have been balanced any confounding factors equally across the groups. The answer is yes here. They used computer-generated randomized tables. There was adequate concealment of allocation. The answer again is yes, because they used double blind, and rather the investigators or the authors are again a different group who were not involved in the patient care directly. So they were blinded to all types of even after randomization, the treating physician could know whether this patient falls in the pre-receptive group, post-receptive group, or receptive groups because of the day of transfer is decided according to the ERA report. But the people who analyzed the data, collected the data, they were not aware of these things. So they only came to know of the results after the protocol was completed for that particular patient. The groups were comparable at baseline, including all major confounding and prognostic factors. Yes, they were. Even the transfer, the blastocyst age were almost 80% were day 5, and some, I think 20% were day 6 or 7, but they were equally distributed among both the groups. So all, if you see all the factors, they were equally distributed among both the groups. Based on your answer to above, your opinion, was there a selection bias? The answer, I think here you can say clearly no. Next, the lack of allocation concealment is a big factor. You may have randomized, but if it is not blinded, then those enrolling patients are aware of the groups or period in a crossover trial to which the next enrolled patient will be allocated. So a major problem in pseudo or quasi-randomized trials with allocation by day of week, birth date, chart number, etc. So randomized tables or throw a coin or something, they are better methods of randomization. Next. So performance bias. How does performance bias affect? What are the components of this? The comparison group received the same care apart from the intervention studies, because here the whole protocol was just the same: frozen embryo, blastocyst, and blastocyst quality was also selected. And so all medicines, etc., were also uniform. So care plan was same for both the groups. Here, participants receiving care were kept blind to treatment allocation. I think here it's no, because they would have known the results of ERA, because depending upon that, their transfer date would be decided. So participants were not blinded to treatment allocation. So they would come to know. This was inevitable in this type of study. Individuals administering care were kept blind to treatment allocation. No. Yet the doctors also would know indirectly that in which allocation group the patient falls. So based on your answer to the above, in your opinion, was performance bias present? If so, does it likely to affect the selection, likely to affect the outcome, direction of the effect? It's difficult to say whether it is opinion was bias was performed or not. Performance bias was present or not. But I think we can say that it did not affect the direction of the effect, because this was part of the study and that was the intervention group which had to be there. Next, please. So lack of blinding, patient caregivers, they have to be blinded, both double blind, what we call. The patients and caregivers should not know. But in addition, those recording the outcomes, those adjudicating the outcomes or data analysis are aware of the arm in which patients are allocated and medication currently being received in a crossover trial. In this study, patients and caregivers would finally know the allocation, but that too at the last moment, not in the beginning. And those recording outcomes, those adjudicating outcomes and data analysis, they were not aware of the allocation. So probably the studies are again free of this kind of bias. Next, please. Then attrition bias, the loss. All groups were followed for up to an equal length of time for analysis were adjusted to allow for differences in length of follow-up. But here, I think the follow-up was complete. So the answer would be yes. The groups were comparable for treatment completion. How many participants did not complete treatment in each group? They were also here. The answer is yes. The groups were comparable with respect to availability of outcome data. Many times patients, you don't even know whether patient ultimately what happened to the pregnancy. Here it is yes. And based on your answer, again, is there any attrition bias? Perhaps no. I think all the patients, 98% of patients randomized completed the protocol. So attrition bias may be there because of incomplete accounting of patients and outcome events, loss to follow-up, failure to adhere to intention to treat principle in superiority trials or non-inferiority trials, loss to follow-up and failure to conduct both analysis considering only those who adhere to treatment and all patients for whom outcome data are available. I think here also the analysis, both analyses are available. So we can say that this bias is not there. The significance of the authors have highlighted the limitations of the study, that they did not analyze data for non-receptive endometrium separately. So, I mean, that's one of the post hoc analysis which can be done, but still that would not contribute to attrition bias. The significance of particular rates of loss to follow-up, however, varies widely and is dependent on the relation between loss to follow-up and number of events. The higher the proportion loss to follow-up in relation to intervention and control group event rates and differences between intervention and control groups, the greater is the threat of bias. Like in these, where the primary outcome is live birth rate, if you have loss of follow-up during pregnancy, then your final outcome data would be fallacious. Incomplete or absent reporting of some outcomes and not others on the basis of the results. Many times especially in small studies, people do that. If the result which they don't like, they just don't report it. Or it's unexpected result which they see, they would not report it. So that comes under incomplete or absent report. That is some part of the data or some part of the conclusion we just hide. You don't show it. Next. Then how the outcomes are ascertained, interpretation, and diagnosed or verified. The study had an appropriate length of follow-up. Yes, it did. The study used a precise definition of outcome. Many times outcomes are not precisely defined. So here it is yes. A valid and reliable method was used to determine the outcome. You have to define all the outcomes in the very beginning, that how do you define these outcomes. Live birth, I think they have defined the live birth by when the pregnancy crosses 26 weeks or something. I just missed out that part. But I think they have defined, because this is one of the definitions.
Yes, they have defined live.
Investigators were kept blind to participants' exposure to the intervention and other important confounding and prognostic factors. I think there were no confounding factors as far as we can see. And so blinding, you can say yes, because we don't know the allocation. And based on your answers, how do performance bias is there or not? So perhaps my conclusion would be that there was no performance bias. Next. So then finally, what is the quality of the studies? Is the methodology used for RCT sufficiently robust to permit a valid conclusion? The answer would be yes, because we got most of the answers as yes, except for a doubtful or can't say kind of caregivers bias or patient knowing the outcome of ERA. And methodological quality, again, it's good. Yes, I think the answer they've said yes, but I think it should be good or see, usually it is rated in plus plus or plus plus plus. So if you give the rate or grade, then it would be the highest grade would go to this study. And with that, thank you very much. I hope I have been able to clear some doubts.
Thank you, ma'am. It was an excellent talk, and I think you very well explained the various kinds of biases and beautifully showed us with the tool how to assess an article when we are seeing and how to look at the level of bias. So the house is open for any questions. Do you have any? Dr. Ruma, Dr. Mohan, any your comments, please?
Yeah. It's on the WHI study. Dr. Jindal, I have a question for you.
Yeah, speak, but recently I've not read the study. I just gave the example.
Of a study that had biases. So I have a different opinion because I read that study and I use that as examples to explain certain concepts, relative risks and incidence rates and ratios. I do agree with you that this was a study that kind of exposed HRT in a very negative way. Except that you have to understand that this was done in postmenopausal women between 50 and 79 years of age. Not every woman in the study suffered the symptoms that women suffer during transition. And so this was being taken for all kinds of random things, but largely by women to protect or prevent themselves from the risk of stroke, cardiovascular events, because that was the thinking. Of course, the results came out to be very different. But in terms of scale, in terms of recruitment, this was a prospective study, a prospective observational study, looking at outcomes that would otherwise rarely happen. And its follow-up duration, it was meant to be a 10-20-year study, but they had to stop it somewhere in between because they found that there are too many adverse effects and they need to stop it right away. It had a control group. And it kind of course, it exposed it. But what perhaps could have been done and was, I think, a communication of these facts that this is not safe in these women, which could have been done early on. Of course, we know this today, but maybe soon after, they could have talked about the patient population that we are talking about, that this is, elderly. These are women who are seeking to reduce their risk of cardiovascular events. And things like oral, it's a certain kind of preparation that is leading to this, and not, this is not a statement on all of it. But I use this as an example to convey the actual risks that the paper talks about. And the risks that it talks about are, in terms of incidence rate difference, that's about 7 extra cases of, let's say, CHD or coronary heart disease events in women per year per 10,000 women. Now, that's not, if you look at personal risk, based on that denominator, the personal risk doesn't appear to be very high. Of course, most of these events occurred in women more than 60 years of age. But what that study lacked, or the authors could have communicated better, was sort of not create that panic and perhaps talk about that the personal risk is still not very high. So yeah, I don't think it was a biased study. I think it was randomized very well. It received the very large numbers of women, 60,000. I think it was some 160,000 women who were enrolled in this.
Thank you. I think that goes with the, interpretation bias. Interpretation could have been a little better worded.
Okay, all right. So
Thank you.
no one has any queries?
Yeah. So I think I would like to thank the organizers, me on behalf of our convener, Dr. Ruma, and Dr. Siddharth, the co-conveners. We would like to thank all our experts who have taken their time out to explain all these concepts in a very simple manner and in relation to the clinical articles. And this is just to give you an overview that how to interpret your clinical data, all your research articles, and will help you in research further on. So with this, I think I would like to end the show for tonight. And thank you all.
Thank you.
Thank you. Thank you, Garima, for inviting.
Thank you, ma'am. Yeah,
Thank you.
Thank you, Dr. Mohan. Thank you, Dr. Yeah, thank you so much.
And Dr. Geeta.
And Dr. Geeta. Thank you. Yeah. Okay. Bye.
Bye.